Good morning, everyone. It's a pleasure to be here in this amazing meeting, Elevation Mastery Latam M22 Day. I'm Dr. Claudia Marçal, dermatologist in Brazil. Thank you for inviting me to be the moderator of the international block. I would like to thank all the present audience as well as Luminance for this incredible opportunity. Now I will introduce the Honorable Dr. Matteo Tretti, who is a plastic surgeon in Milan, Italy. He's a specialist graduated for the University of Pavia. He was the medical officer in Arma dei Carabinieri and started humanitarian missions in Bangladesh and Africa, mainly performing reconstructive surgeries on burns and congenital malformations. He's now more focused on cosmetic procedures and laser treatments. He started his laser activity in 1996, has been teaching since 2005. Author of more than 190 articles, lectures, and national and international meetings, and belongs to more than 10 scientific associations. He's the founder, CEO, and medical director of Laser Plasty Milan. He's the author of 196 publications and has participated in 251 national and international congresses. He was an invited speaker at 138 of these congresses. Dr. Matteo, could you begin your lecture about combined therapies with M22 photofractional, please?
Thank you so much, Claudia, for a very kind introduction, and thank you, Joao and Luminis. Before starting, I want to say to you all that I hope to be able to see you in person after this terrible pandemic, and I hope to meet you directly. And I think that I can be absolutely more, we will be more excited about that. Luminis invited me to speak about the an evolution of the M22 procedures. So a combination of two of the most important handpieces they have there. So the new IPL with the OPT technology, as well as the true non-ablative fractional as the 1565 nanometers is. These are my disclosures, but it's not important, I think, for this meeting. So combining IPL with non-ablative fractional is not a news, is nothing new. Already in 2012, 13, and 15 appeared in the international literature papers speaking about the same session combination of these two different technologies. But these papers are not related to the 1565. And if we go deeper inside that, you can see that there are only three. There are not many. All of them are demonstrating that the combination of IPL and non-ablative fractional are really effective and more effective than the single procedure alone. All of them are demonstrating that the combination are absolutely safe. Unfortunately, two of them have a very short follow-up, only 1 month follow-up. And while I will show you my cases, and all of them have at least 6 months as follow-up. And so I do not think that showing results at 1 month can be a good idea because we can still have some redness and or some swelling. All of them presents a period between the sessions of 4 weeks, and this is what I'm doing usually every single day in my office. But going back to the Luminis device, if you go again to the literature, you can see a couple of papers extremely interesting regarding the non-ablative fractional. I think that everyone knows the IPL, but if you go here in a paper published in 2011, and in the other one published in 16, we can see that after the 1565 procedure, we can have less elastosis and restoration of candelabra-like network in the dermis. And we can have, after the procedure, a thicker epidermis and the better undulating dermoepidermical junction. On the other side, in a paper published by my close friends Gilly Munavalli from Charlotte, North Carolina, he demonstrated that we have an evident coagulation just after the procedure, after the 1565, and we have a robust, and this is very interesting, a robust increase of collagen and elastic fibers inside the dermis. So because of this, the idea was why not to combine two procedures that you can do with the same device in the same session, in the same day, on the same patients. Gerd Kautz, that is another close friend of mine, is living in Germany. Finally, in February 19, published this paper. And in the conclusion of this paper published on the Red Journal, you can read that the same day combined IPL and non-ablative fractional regimen proved safe, and this is very important, and determine a significant skin rejuvenation without prolonging the downtime of each individual modality. The question I received every time I speak at the meetings regarding this combination is, okay, Matteo, but what about the downtime? We do not have a longer downtime if we add a non-ablative fractional, if we consider that of a non-ablative fractional alone or a non-ablative plus the IPL. He demonstrated that we have a great improvement in texture, tightness, pigmentation, brightness, and the overall appearance of the face. But what is this combination? What is the science behind the shoulders of this? Okay, with the IPL, everyone knows that we have two targets, melanin and hemoglobin. The energy delivered by the device is fragmenting the melanin and is coagulating small vessels, but are doing this job in the grand zone, in the very superficial layers of the dermis. While we know also that the 1565 or in general non-ablative fractional are affecting water. So we can go deeper if compared with IPL. We are not affecting, or we have a minimal effect on melanin. We are not affecting hemoglobin, but we can coagulate the dermis. We can have very thin columns of coagulation inside the dermis. The second question important is which first? With which one to start, IPL or non-ablative fractional? I am sure that we have to start with IPL. If we start with non-ablative fractional, at the end of the procedure, we can have too much swelling and we can reduce the effectiveness of IPL. So my idea is to start with IPL and immediately after the end of the procedure, please proceed with a non-ablative full area procedure. So the idea is this: we can deliver the energy with the IPL first, affecting melanin and affecting small vessels. We are fragmenting melanin, we are coagulating vessels, but the most important thing is that we are diffusing heat to the surrounding tissues. And we know that heat means new collagen production. Just after that, we can proceed with a non-ablative fractional procedure, and we can cover the same anatomical region of the face. So we have three different targets: melanin, hemoglobin, water. We have at least two different layers of work. One is very superficial because of the IPL, and the second is much deeper, considering the non-ablative fractional. Both of them are stimulating new collagen production. So in a practical point of view, I love to be practical. I naturally suggest to clean the skin with disinfectant. I apply a numbing cream composed by 7% lidocaine and 7% tetracaine, and I leave that in place for 45 to 60 minutes. Then I proceed with a full face IPL procedure. Usually I apply a cutoff filter of 560 with a double pulse with the subpulses of 3 and 5 milliseconds and the delay regarding or following the skin type from 20 to 35 milliseconds. And I apply an energy from 18 to 21 joules square centimeters. Then I change the cutoff. I use the shortest we have, the 515, with a single pulse, with the shortest pulse duration we have 4 milliseconds, and with the highest, not the highest is 15, but I use 14 joules square centimeters on each single lentigo or blemish we have to have a very great effect on that. Just after, I change the handpiece and I move to the non-ablative fractional. I use a medium length linear pattern and I try to follow the base of each wrinkle in the face of my patients. The idea is using high numbers of microbeams, 300 to 400 MBS per square centimeters with a very low energy. So remember the general rule, higher the density, lower must be the energy. And finally, I cover the full face with a big hexagon or circular pattern using a medium amount of microbeams, usually 250 MBS per square centimeters, with an energy ranging from 40 to 45 millijoule for square centimeters. Then I apply a moisturizer. Then I repeat the procedure 4 times at 4 weeks apart, and I do not suggest any prophylactic therapy. This is what I showed at the SLMS meeting in Denver a couple of years ago. Is the same thing I tried to describe you. So the first pass is a 560 cutoff filter, in this case on treating on the décolleté, 560. Then I use the 515 only on single blemishes. Then I change the handpiece. I use the medium length and linear pattern, and I'm trying on the face as well as on the décolleté to follow each wrinkle. And the idea is to deliver the energy exactly where we need at the base of each wrinkle, exactly where we need new collagen production. Then I change only the pattern. I use a circular or an hexagon one, and I naturally change the settings as I already described to you. And finally, why not to use the same non-ablative fractional again on each single lentigos using very high number of microbeams and a very low energy. The idea is trying to arrive not to adjust around the DE, and so to increase the elimination of melanin that we can have there. So starting with cases and trying to keep it in time, this is a patient of mine that I treated with this combination. So you can see a superficial photo damage, some wrinkles on the cheeks, and some and deep nasolabial folds. I didn't inject anything in her face. So look at the crow's feet, how that's improved. Maybe not moving is better. We had an improvement in the crow's feet area and the less deep nasolabial folds. We have a better texture of the skin, and naturally, because of the IPL, an improvement of the superficial photo damage. Another patient, an older one, again, superficial photo damage, a lot of wrinkles around the eyes. Look at the queue and the head of the eyebrow. We didn't inject any botulinum toxin over there. So we had an improvement of wrinkles as well as the skin laxity and skin texture. So without the movement, look at the crow's feet area, look at the superficial photo damage, how we were able to obtain the results also on the other side. Light skin type patients, every one of us, every laser operator really loves to have these light skin patients. We can be much more aggressive on her, avoiding any PIH after. So we had a great improvement in the quality, in the superficial quality of the skin, but look at the texture and the wrinkles. She was presenting before, and she's not presenting after. And also on the other side, this is absolutely evident. This is a more severe case, darker skin patients, a lot of big lentigos. So here the defect is much more superficial if compared with the deep one. So we had improvement in the crow's feet. We had improvement in the skin texture, but I think that here the greatest advantage of this procedure is to improve a lot the quality of the superficial photo damage. So this is the right side, 3/4 of the right side, and 3/4 on the left side. And another patient, classical patient of Milan here, North Italy. So blue eyes, light skin. They are spending a lot of time in Maldives, so a lot of photo damage, wrinkles around the eyes. Again, there's no difference. The distance between the external canthus and the queue of the eyebrow is the same. So we didn't inject botulinum toxin, but look how we were able to obtain an improvement on the wrinkles over there. Look at the laxity of the skin along the jawline, and look again how much deep was the nasolabial fold before and how that improved after the procedure. And this is the same patient where the improvement is much more clear. If you look at the left cheek, look, no more deep wrinkles on the left cheek, great improvement of the superficial photo damage. She's a colleague. So again, a great laxity, a lot of photo damage. She didn't accept any surgical approach. She wanted only something that she can repeat every 4 weeks. So this is what we did. And as you can see, we had an improvement, not 100%, but we had an improvement of the skin laxity along the jawline, but we had a great improvement of the superficial photo damage as well as the skin texture. And this is the same patient on the left side. And another one, again, light skin, superficial photo damage, a lot of wrinkles in the crow's feet area. Look how she improved after the procedure on the right side as well as on the left one. But we can apply the same protocols, maybe reducing some settings, not the pulse duration, not the cutoff, but regarding the IPL, we can reduce the energy, and this is maybe is not rotating. And we have to reduce the energy of the non-ablative fractional. However, this is a décolleté. These are the cases I presented at the SLMS 2 years ago. Look, this is a décolleté before and after. Great improvement of superficial photo damage, but great improvement also on fine lines and deep wrinkles. So this is another one, again, before and after, and not the rotating pictures. Look, all blemishes disappeared, and we had a great improvement of wrinkles as well. So probably this is the last one. A lot of blemishes, more wrinkles in between the breast, and with a great improvement also on this difficult area. And this is the non-rotating picture. So I want to thank you, all of you, and I will be more than happy to answer to eventual question I will receive.
Thank you, Dr. Matteo. Congrats for your lecture. It's amazing. And I have some questions for the audience, and I have a question for you too. There is one for the audience, but I think you speak about this, but at what moment do you apply anesthesia? Which one do you recommend? And should you prepare the patient with oral or local tranexamic acid to avoid PIH?
I apply a numbing cream. I do not know, Joao, if I can say the name of this drug. However, it is a 7% tetracaine plus 7% lidocaine. Is of a Canadian company. The name started with the letter P.
No, you can, doctor. No problem.
I can. Yeah. It's Pliaglis. It's Pliaglis.
I leave the the same. I use the same.
Yeah, I leave that in place for 1 hour, and then you can remove it. I think that that is the most effective numbing cream I ever tried in my life. To avoid PIH, tranexamic acid is a brilliant idea. Unfortunately, in Italy, 8 months ago, the company who is producing tranexamic oral pills of 250 milligrams stopped to produce it, I think only for economical reasons. So I asked my patient to try to buy it in internet, but it's a great idea to reduce the risk of PIH. To be honest, I do not have a lot of so dark patients. So these are my recommendation, but only in a few of them and not in all of them.
Okay. I use tranexamic acid in Latin America because you have the phototype 4 to 6 in more population, but I can you use the other antioxidants that control the pigmentation, such as glutathione and Polypodium leucotomus and others that control the PIH and the sunscreen all the time. And I have the questions for you. What is the main difference in the results when you use only IPL or non-ablative fractional laser compared to when you use both? Or is it important to use both in your opinion?
When you are using IPL, you are affecting superficial photo damage, but it was difficult in my hands to obtain to achieve very good results on wrinkles and on laxity. I do not think that IPL can affect skin laxity as well as deep wrinkles or wrinkles in general. So I think that there are two kind of population. On one side, people who are willing to accept, for example, a fractional CO2. On the other side, we have people that can accept IPL, but there are tons of people in the middle that deserve something more than a classical IPL and are not willing to accept a 4 to 5 days of downtime as the CO2 is creating. So that is so we are affecting more with laxity and wrinkles with non-ablative fractional, while we are affecting more superficial photo damage with IPL. But Claudia, I try to, if my Spanish, I don't speak Spanish, but if my Spanish is correct, I will try to answer to a question of Claudia Marcela Gaviria Giraldo that is interesting. Is not affecting the IPL, the application of numbing cream is not affecting the IPL procedure. Yes, but this is what I want to obtain. The adverse events of applying Pliaglis is having some redness. But I have some redness, I have more target. If I have more target, I am more effective. So I pray to have some redness after the numbing cream application, because having more targets, I can be more effective. Cesar, I need a question from you.
Dr. Matteo, nice results. But what is the time between what session? 1 month, just 1 session, 2 sessions, 3 sessions? What is your life?
4 sessions, and the time between the sessions is 4, sometimes 5 weeks. So the procedure is 4 to 5 months.
Okay. Dr. Matteo has another question. How you apply this tech in the periorbital area?
How I apply, sorry?
Periorbital area.
Okay. So staying on the bone and not going inside the eyelets, you can stretch the skin. If you can see in the monitor, I will try removing my glasses. You can stretch back and you can open the skin over there like this, okay? So with the line shape, you can affect the base of each wrinkle. and this is to have new collagen production at the base, and then again stretching the skin and trying to stretching that back while stretching, because if you stretch the skin, you make the skin thinner, and if you make the skin thinner, you can go deeper with the same settings. So doing that, and then I do a full area with the circle or the hexagon pattern. Here the skin is from 0.7 to 0.9 millimeters on the eyelids, and there is just a little thicker. So I suggest you to reduce the setting I show you, and you have to use on the cheeks, but not too much. There you will have a lot of swelling, but for a short time, and it's only 2 to 3 days, no more. Now I have to reply to goggles, otherwise I cannot see anything. Okay.
Okay, I have a last question for you. It's my question. In Latin America, we have many patients that present melasma, rosacea, and acne with high pigment scars, as well as texture alterations. What are your suggestions for each one of these alterations with IPL and herself effects?
Because I love to be always honest, I do not suggest at the beginning to use IPL or non-ablative fractional on melasma. I prefer to use chemical procedure, and to be honest, now I'm using picofractional. On acne scars, I prefer other approach at the moment. I prefer injection of hyaluronic acid with the pneumatic injection plus fractional CO2 using the ultrapulse. But considering the skin type, you can use the non-ablative fractional, but you cannot consider that you can have the same results with non-ablative if you compare that with CO2. I think that for dark skin patients, what we have to do is trying to well prepare the skin before, as you suggested, Claudia. So I love to use tranexamic acid. The other thing is trying to reduce as soon as we can the inflammation in the post-procedural time. So sometimes I suggest to use clobazole, so a fluoride steroids mixed with a moisturizer for 2 to 3 days, cold from the refrigerator at night. And naturally, to follow up that patient strictly means looking at them every 15 days and eventually start with a modified Kligman-Willis formula. So 0.025% tretinoin, 4% hydroquinone, 3% vitamin C, and 1% of hydrosteroids, or 0.1 of fluoride steroid if you have that in your country.
I do the same procedures after the IPL photofractional with the Kligman formula, or with dihydroquinone with the another depigmentations. I use a lot of sunscreen and cream recover with the steroids to decrease the pH, the hyperpigmentation. Thank you so much.
I will be here for the full meeting, so I'm really interested, and I'm really curious to hear from all of you about your expertise. Thank you so much.
Your lecture was amazing. I think everybody learning a lot with your performance, was your contribution.
Thank you.
Thank you.